thought out system, the healthcare system in the United States. We'll have as many massive systems as possible, all duplicating the services that patients get. This is brilliant. The person who came up with this, you have to, probably a Republican. I'm sorry. Anyway, so the answer. What's the answer, Dr. Eddy?
So, I think yes, you can provide services to hospice settings.
Yeah. Yeah, to my knowledge, it's a certified hospice agency providing a team in the prison. Prisons don't have their own agencies. Okay, very quickly, so these are the myths, among others. There are many myths. Hospice is not a place. It's a home care program with access to beds. Hospices can provide disease-modifying therapies. If you define the word curative as meaning prolonging life more than 6 months, to a reasonable degree of medical certainty. If you define the word curative like that, then hospice cannot provide curative therapies. If you define the word curative as meaning curing, then it's moot, because nothing we do in hospice for hospice patients cure them. So the word curative, it is a true fact. If a patient is given a curative therapy, they're not eligible for hospice, because if you're cured, presumably you'll live more than 6 months. It's just illogical to think about, because the overwhelming majority of patients, except for the rare patient who has access to Gleevec, the overwhelming majority of patients will not be cured. So calling the therapies curative basically affects almost no one unless you redefine the word curative as meaning prolonging life more than 6 months. If you define the word curative as disease modifying, you become like most hospice agencies in the country. But unfortunately, that's taking a financial argument and giving it the glimmer of medical decision-making, which everybody does, but makes me uncomfortable, so don't do it. Makes me very uncomfortable to not be honest. I call them proxy words. You know, you go to meetings and you hear all these people saying things using words that don't mean what normal people would think they mean. You know, like curative. So, you know, I worked in a cancer hospital for 10 years. I never saw anybody with an advanced lung cancer get cured by chemotherapy. It doesn't happen. Do hospice programs require the patients to give up their primary physician? No. Common myth. Do patients in a hospice program have to be DNR? No. Common myth. Okay. What about the role of the physicians? There are three types of relationships if you're a physician, or an NP, actually. There are 3 types of relationships that you may have with a hospice. So one type of relationship is called an attending physician. So an attending physician is, do you know how the government defines the attending physician? This is apropos of what you were saying, Stephanie. So the government will not let you say what's curative, but the government will let you say who your attending physician is.
Whoever you appoint?
Yeah, whoever you appoint. So a patient has the right to say, that's my attending physician. Now, how does the government decide? What does the government do with an attending physician? The government has the hospice agency put the attending physician's name into the computer that controls all the activities of Americans. You may think that you have free will, but you don't. We're all being controlled by computers out of Washington. Did you know that? It's true. That's true. And so as an attending physician, your name is in the computer. And what the computer says is, if I receive a bill, a Medicare bill, under a so-called 1500 form, if I receive a Medicare bill, and it's a Part B bill for a physician, right? Part B covers physician billing. I will not pay it unless I have the name of that person in the computer. I will only pay Part B bills for that one doctor or NP in the computer. That's who the attending physician is. The attending physician is the only physician interacting with a hospice patient who is allowed to bill, who will get paid. Not allowed, anybody can bill anybody, but it's the only physician who will get paid when billing under a routine Part B billing system. Every other physician who drops a bill goes into their office and says to their secretary, I need to bill Miss Jones. Just electronically submit a bill for endoscopy. And that gastroenterologist, say, puts a bill for endoscopy under Part B for Miss Jones, who's a hospice patient. He gets an explanation of benefits saying rejected. And this is why a very large proportion of physicians, at least in the New York metro area, think that they don't get paid for hospice care. They think that taking care of hospice patients is pro bono work, is charity work. And this is not true. It's because if you are not the designated attending, in quotes, the attending, you're only one. If you're not the designated attending and you bill the government, you bill Medicare, you will not get paid. So that's one type of physician. A second type of physician is called an employed physician. An employed physician is either a hospice medical director or a physician designee, a medical director designee. These are physicians who have contracts with the hospice and have a series of responsibilities as a medical director. Oversight, oversight, administrative responsibilities. The key thing about an HMD or a designee is that they can sign CTIs. Right? So the employed physicians who are designated as hospice medical directors can sign patients into hospice. Now, can these physicians bill Medicare? Yes, they can. But there are two issues, and they're really important. Issue number one is that they have to bill under Part A. If you have a contract with hospice, you're not billing under Part B anymore. Remember, anybody who bills under Part B is getting rejected except the attending. So you're billing under Part A, which means you bill the hospice. Number two, you can't bill for that part of physician services covered under the per diem. The government gives a per diem to the hospice agency, which includes medical services. It's right here in the COPS. Administration, oversight of the care plan, signing of documents like a CTI. If you bill for those, that's fraud. You can only bill for professional services that require a physician's input and are outside of the administrative responsibilities of the hospice medical director. So if you go see a patient and adjust the pain medication, you can bill hospice, and the hospice will collect those funds, and they may or may not distribute it to you. That depends on the relationship with the hospice that you have. But if you bill for going to an IDT meeting, that's fraud. Or if you bill the hospice agency and the hospice agency then bills up through Part A for your time spent doing oversight, that's fraud. You have to see the patient for a so-called billable physician service or billable NP service, and you have to document it's a billable service and bill under Part A, using the same codes that we use in the Part B world. Use the same codes. What's the third kind of person? Right. So they call it a contracted physician. I always think a contracted physician is like a little raisin physician, somebody who's very dehydrated. So I like the word consultant. Consultant physicians need a contract with hospice, and they bill Part A, not Part B. If you're a consultant and you bill Part B, what happens? Denied. You're a consultant, you bill Part A, you get paid. However, the requirement is that what you offer the patient has to be part of the plan of care. So hospices, if they're feeling very tough, could deny consultants payment if they have not spoken to the medical director or the case manager about what they want to do first. And it doesn't appear in the record. So ideally, look, if you're a consultant and you want to amputate a limb, I would suggest you talk to the medical director, you talk to the case manager, and the plan of care says amputation of limb. Then you bill hospice for the professional services related to that amputation, that surgical procedure, using the same CPT codes, and Medicare will pay you under Part A.